introduce you and turn you over to Dr. Dena Cabrera.
Hi, welcome. It's good to have you here. We're kind of launching, today's our first educational outreach series that we're launching through our Tempe IOP program. So it is nice to have you all here, and we welcome you. So I'm Dr. Dena Cabrera. I'm a clinical psychologist, and I'm the director of adolescent services at our Rosewood Ranch, or Rosewood Centers for Eating Disorders up in Wickenburg. So it is nice to come here today. We were rained out a few days and had to go an alternate route through New Mexico and then up to the ranch. So it was quite an ordeal. So it is nice to kind of go through straight roads and get here today. So I've been working with patients with eating disorders for over 16 years. I guess you could say that's pretty much my specialty, and of course all the comorbid disorders that go along with it. When I first went into eating disorders, people in my graduate program were saying, "You sure you want to narrow your experience, or you want to just expand that a little bit?" And I've found that working with eating disorders, you get a little bit of everything. So it has been quite an experience, and certainly my passion. I work with adolescents now, and we have facilities that, for our program, a 14-bed facility. We treat both males and females there. And then it is attached, or separate but attached to our adult program, which is 28 beds. And we, again, serve anyone from 18 to 78 or older. And in that program, we have our more intensive program, and then we have a residential setting. And we have about 28 beds, I believe, for that program. And then we have our step-down program, which is our partial hospitalization. And even though it's in the same town, but it is a few miles away, and it is if you will, the transition between our residential and an intensive outpatient program. And so they still have 24-hour care, but a little bit more of a less restrictive environment so that they can practice their skills, cook their meals, shop for their meals, in a still safe and therapeutic environment. So that's our Rosewood Center, and then I'm going to turn it over to our director of our Tempe IOP program. But I'm going to read his bio really quick. He's the clinical director, and he comes with a breadth of experience as a master's in social work, and he's from West Virginia University, and has had his LCSW since 2004. He's worked in a variety of different programs, inpatient and outpatient, for over 13 years, and he's held his own private practice as well. He's worked with youth with trauma. He's worked actually in a breadth of experience, including eating disorders, sex trafficking, trauma, drug and alcohol addiction, and sex offending. And he's also an adjunct professor at ASU. So I'd like to turn it over to Mike Klinker.
Good morning, everyone. Thank you. So I'm just going to be a little bit, because as you see, I'm nowhere near the star of the show here at all. So I'm just going to talk to you a little bit about...
We even put you on there, didn't we?
I know, right? I can write on the board, I think. Thank you guys so much for coming. Like she said, this is the first of these, but certainly not the last. This is the big kickoff. And we know there's not a lot of great education going on in the Valley about eating disorders. And Rosewood is an amazing place and an amazing position, because we're right here at ASU. We're right sort of in the center of everything, and we're part of this continuum that Dena talked about. And as we know, no matter what the problem is, from substance abuse to eating disorders to whatever, ideally you have a real big continuum of care, and that's everything from detoxification to hospitalization to residential care to partial hospitalization to outpatient. That's Rosewood. We've got that, and it's amazing because it's us, and we're all steeped in the same theory, the same concepts, and you're going to hear some of that today. And what that means for our clients who, if they start here, and hopefully they never have to go anywhere else. Hopefully they come into our outpatient, intensive outpatient, and we can work with them here. They can be within just outpatient sessions, which means you're just seeing the therapist once a week, and we could do family therapy and rectify issues that way. Or if you have to do our intensive outpatient program for both adolescents and adults, and you can see there's some amount of this information in your program, and so I'm quite sure you all know how to read, so I'm not going to go through that all totally. But for the adult, it's 5 days a week. And it's you have to eat your meals here, and we do meal challenges, and it's everything from psychodrama to DBT to EMDR to cognitive behavioral, and we know that's what works, and we do that really well. We're confrontational when we need to be, we are loving when we need to be, and we see amazing results with our clients all the time. And sometimes they have to stuff up, and sometimes that's all the way to the highest level of care. Sometimes that's Capri, but you're able to move flexibly about what makes the most sense for that client given where they are. How much external structure do they need, or how much don't they? And that's what Rosewood can provide very, very uniquely. There's not a one of these in Arizona. We're uniquely positioned to deal with this clientele, and that's a really big deal, and that really serves them best. You're going to hear a lot today about how much we look at the trauma and what a big deal it is, and codependency, what a big deal that is. Because if you don't work with those core issues, you're just putting Band-Aids on it. And you'll get it together for a little while, and it'll be just fine. And then 6 months later, you're going to go, what's going on? You're self-sabotaging, everything's not working out. No, it's because you missed the core issues, and if you don't take care of that, we know with our clients, they don't progress, not for real, just for a little bit of a time, and then they slip back. And so you're going to hear a lot about what to do with that and how we do that here, because we know that it works, and that's a great part. A little bit later, you're going to get to see the facility, about how things work. The adolescent program as well. Again, it's very, very unique. There's no one else doing exactly what we do here. It's 3 days a week. Again, it's the same DBT, CBT, psychoeducation, and EMDR if needed. And so we're working on those major core issues for the young women and young men under 18, and that's everything from 12 up to 18, and working what we know does best and what we see is effective all the time. And so, and again for them, there's that same continuum of care that goes the whole way up to the hospitalization, detoxification if needed, all the way down to outpatient sessions. And that's Rosewood, and that's what makes us so great, and that's what makes it work so well. So I'm going to tag back in our illustrious presenters today that you get to hear all this stuff about. But I'm around if there's any questions, anything along the way. Please feel free to grab me. You have all of our information if you want to contact us, or if there's any other reason why you want to come by or see something or anything like that. You guys are always welcome for that too. But again, thank you. I would encourage you to eat, but if you don't, that means awesome leftovers for us. So fine, don't eat. I'm cool with it. And thank you guys so much for being here.
Thank you.
Great, thanks. Okay, so I'm going to introduce our presenter, but I think if I may, can we go around the room and have you introduce yourselves and just tell where you're from, because I think this is also a wonderful opportunity to network and get to know each other, and then you can kind of put a name to a face sometimes. So if you don't mind starting, that'd be great.
I'm Jennifer Siosis, and I'm with Mountain Health and Wellness.
Great, and where is that located?
Well, we have several regions.
Okay.
We have the office closest to here would be in Apache Junction, and then we have Superior, Kearney, Oracle, San Manuel,
Oh, wow.
Yuma. Did I miss anything, guys?
Queen Creek.
Okay.
We all cover all these regions.
Okay, great. Welcome.
Thank you.
I'm Jacqueline Zengler, and I was an intern with Impact Suicide Prevention Center, and I'm currently searching for a job.
Oh, yes. Been there. Good luck with that.
Thank you.
Mhm.
I'm Judy Thorne, and I'm with Impact.
Okay, nice to meet you. Hi.
Hi, I'm Karen Curtis, and I'm with Impact's Trauma Healing Services.
I'm Lisa, I'm also with Impact Trauma Healing.
Great.
I'm Amy Polisano, I'm also with Impact Trauma Healing Services.
And I'm Emily Aslan, and I'm
So all this trauma experience, I think you guys should come up and do the talk. Yes.
I'm Maria McKivergan. I'm not from Impact.
Okay.
I am from Mountain Health and Wellness in the Yuma region.
Okay.
I'm Brittany Murphy, Mountain Health and Wellness. I cover Queen Creek and Apache Junction.
Wow, okay, great.
I'm Shonda Baker with Mountain Health and Wellness. I cover outpatient in Apache Junction and the crisis services.
Wow, so you were all over a little bit, huh?
Hi, my name's Charlotte Denton. I'm with Mountain Health and Wellness, and I work with the SMI population.
Okay, great, wonderful, welcome. I'm going to introduce our speaker today, or one of our speakers. I'm going to go first for about 15-20 minutes, and then Stephanie's going to take it over. Stephanie has a master's in counseling, and she has quite the clinical experience ranging from trauma to crisis response and eating disorders. She is been working with eating disorders for almost 2 years, and then before that 4 years in full trauma specialization, including dissociation and attachment theory. Stephanie was trained in EMDR in 2007 and uses it regularly here with our patients, which is a great asset in working with eating disorders and trauma, as you can imagine. She's a lead therapist here at Rosewood Intensive for the adult program, and she's skilled in every kind of therapy you can imagine. She does the group therapy, she does DBT therapy. You're like, sorry. I'm proud of you. I think this is awesome. And domestic violence, sexual assault, eating disorder, education, and prevention. She presents on body image and trauma. So you get a treat with her in just a little bit. So I'm going to start us off a little bit, and in going through this, I have to tell you one of my biggest faux pas in being a presenter, and I know it, is that I put a lot of information and then we don't have enough time. So I've been really working hard at scaling down, but if you have questions or, please feel free to interrupt me because I love to talk about eating disorders. And then afterwards I'm going to turn it over to Stephanie to talk about trauma, codependency, and using the Mia Melody codependency model, if you will. So as we get started, I'm not going to go fully through, all what an eating disorder is because I know you can read a DSM-4, but I'm going to talk a little bit about what maybe the changes are that we're looking at and how that impacts our field. What I've noticed just lately in what I'm seeing in our population is it feels like, at least on the inpatient and residential level, I don't know what you're experiencing, is that our patients, especially who come in with eating disorders, have a tremendous amount of so much comorbidity, the trauma, the dependence, the depression, the anxiety, and it seems like it's very, almost in the psychiatric severity level. We have a population right now at our adolescent center whose eating disorder, I would say 70% of their eating disorder is secondary to their other issues. Adolescents with, alcohol and drug issues, with trauma, with self-injury, and what was the other thing I was saying? Oh, and severe anxiety. So we have a lot of OCD right now in our population. So it's oftentimes, oh yeah, we're dealing with the eating disorder, but it's all the other issues that we're trying to get managed, at least at our intensive level. And then eventually, more at this level, I would say, they often, they deal with all the others as well, but they're often working more on a hands-on approach with their eating disorder. Just getting them to manage their meals is oftentimes the priority. So in terms of our population, I think, I don't know if we've seen actually an increase across the board in anorexia particularly, or bulimia. It feels like it, but it's more of an increase in what this category would be, eating disorder NOS. And I think that's a lot to do with how we're diagnosing, and I'm hoping as the DSM-5 comes out that we'll have more criteria that better fits these who right now are on what they claim don't have an eating disorder. It's not severe enough to be classified as an eating disorder, because when that happens, then they don't get insurance coverage and they don't get treatment because they're not sick enough, so to speak. And we often see that, and I'll explain that a little bit. One of the most shocking statistics about eating disorders is that 20% of those with anorexia will die from their eating disorder. It's one of the highest mortality rates of all the psychiatric illnesses, and it also is the #1 cause, and some of them die from suicide. It's suicide is a huge issue in the eating disorder population, and I think what happens is they become so despondent and hopeless in the midst and in the bondage of their eating disorder that they often take their own lives. When at my last facility, I knew at least 7 with eating disorders who did take their own lives. Just from, over a 20-year span, mothers or parents calling us and telling us, what had happened. So about a third are due to cardiac complications. So it's startling, and I think that is a national health issue that we need to be more aware of. But right now, the funding for eating disorders is just not a priority as other issues like drug and alcohol or some of the other things that they're focusing on. Still focusing on schizophrenia, still focusing on a little bit bipolar and depression. But when it comes to eating disorder nationally, the funding just isn't a priority, which is very sad. So again, I'm not going to go through exactly, but I want to kind of talk about what is going to be different, hopefully, in the DSM-5, whenever that comes out, 2013. One of the things that we do know about this illness is that it is on a continuum, but it also is indicative of the illness, which is a bio-psychosocial spiritual issue. It takes a team approach to deal with this problem. And so what we see is, in terms of the definitions and what the proposals are, oh yeah, it's in red. It shows up better on the computer. But one of the things about the terminology, which is interesting because I never really even thought about this, but the word refusal to maintain body weight, is actually a very much of a pejorative word, and so it kind of conveys that it's their fault, they're doing it on purpose, when in actuality, through the research of what we found, that it is, there is a huge genetic influence and a neurobiological influence into eating disorders. So the word refusal is going to be taken out for the DSM-5 because, again, it states to insurance that, oh, this is something that they're doing on purpose. It states to our culture that this is something that they're doing on purpose because they're refusing. Now, that leads us to other intense discussions, and in the field of eating disorders, they always talk about, well, if they're not doing it on purpose, like cancer, so to speak, then we need to look at treatment different. Well, I think with eating disorders, because there's such a huge behavioral component, there is also an element of choice. So, yes, they may not be doing it on purpose, but they have to take responsibility for it anyway. Like many of our clients, like it wasn't their fault that they were traumatized, but they have to take responsibility to get well anyway. So there is an element of choice, and all that to just say that it's just interesting. A lot of people in the field of eating disorders really approach it like they have no choice. They have no choice. It's not their fault, but I kind of look at it differently. I look at, yeah, you may not have caused this, but you have to step up and take responsibility, and how can I help you do that? So, just a thought. Intense fear of gaining weight, I think that's going to be the same. The other thing is going to be different in the DSM-5 is amenorrhea. It's a little bit of an issue with men and boys, since if we have to have that criteria, then they definitely will not be meeting that one. So, so that again, they're looking at it. You can tell when they came together, they really didn't figure that men had issues, and we know differently. It's still significantly lower than the prevalence in our women and girls. They say the statistics are about 10%. Is that right? In terms of like 10 million women and girls struggle with eating disorders, 1 million men and boys struggle. I think that number is actually conservative because men and boys often don't ask for help and come to treatment. And it's not socially acceptable as it is for women and girls. I know when I was, and still I'll get calls today, and it's mostly, I hate to stereotype, but it's mostly fathers not understanding that their sons have an eating disorder and are very reluctant to admit them into treatment. Oh, that's a girl's disease. Oh, you're just doing that on purpose. And so that's oftentimes we find that there's barriers for them getting into treatment. They often have barriers through insurance companies too. So that's something to, hopefully, when they change some of this, our culture, our field will get the picture that this happens in males as well. My experience is that with boys and men, is their eating disorders are so similar than girls. I mean, the core issues, the underlying issues, the body image distortion, some of the research is different. It contradicts what I just said. They'll say, well, men and boys, they want to get bigger, and we do see that. We see men, working out in the gym, and their emphasis on muscles and their compulsion to over-exercise. But what I've seen, at least, of course, I have a narrow experience in an inpatient treatment center, I've seen that their issues are very much wanting to be thin, wanting to not get fat, distorted body image issues. So,
same at this level of care.
Same, is that what you're saying as well? Mm-hmm. I think on the other end of the continuum, who want to get big and compulsive, that's more socially acceptable, and they're surely not going to come for treatment for that. So, unless depression or other comorbid issues put them into treatment and it's actually identified. As far as bulimia, I'm looking where the red is. The difference, same kind of thing. I mean, we're still going to look at binge purging. There's going to be a certain amount of time. I think what they're going to try to change is the cycle, because with with bulimia, greater than 2 times a week for 3 months, that may not be, they still may struggle with bulimia and not meet that criteria for a time frame. So that's something that they're looking at as well. More inconsistent. We see episodes of restricting, we see episodes of binging, we see episodes of purging, and the reality is they are meeting criteria for this. It's just not exactly in a 3-month time period. It might be over a course of a month or 2 months, and so that's something that they're looking at. The binge eating disorder is going to be a diagnosis, so that's very encouraging because oftentimes we get, you know, insurance. I mean, they come into our, if they even get residential, they'll get partial, and then they're there for 2 weeks, and insurance says, okay, she's done, she's good, you send her out. And it's not realizing the severity of binge eating disorder just because their weight is maybe in a normal or above normal range, so to speak. But it's definitely something that we struggle with. There's a lot of comorbidity with binge eating disorder, particularly alcohol and drug use, as well as trauma. And so something that definitely needs to be addressed on a more, you know, medical level and psychiatric level. So, like I said, about 1 to 3% meet criteria for bulimia, 0.5 to 1% meet criteria for anorexia, and then you have this 25% meeting criteria for binge eating disorder, which is so much more of our population than anorexia and bulimia. Okay, so this slide, this is one of the slides that I really had to cut down on because I could go on and on. I know you don't want to hear all that. But I just want to give you a little flavor of what in our field is happening. Basically, you know, we know that through research is that eating disorders are such a significant, there's such a significant genetic influence. There's not one gene for bulimia or one gene for anorexia, but it's a host of genes that basically code for proteins that influence our traits. And the traits are probably a lot what you've seen and what we see when they come into the door. So the traits in terms of genetic influence are perfectionism, low self-esteem, and a diagnosis of obsessive compulsive disorder. So those 3 traits are what influence or pretty much put someone at risk for an eating disorder in terms of that genetic predisposition. And then there's other things. I mean, we look at the serotonin deficiency syndrome, you know, just not feeling pleasure or having pleasure with food, and so there's just no desire to eat. And then we have with binge eating or bulimia and a dopamine deficiency syndrome, where, I don't know if it's deficiency, it can be an over or under, but it's more of that they can't get satiated, if you will. They can't get pleasure. There's never enough. And so they're looking at biochemical influences and how our brains are influencing the way we eat or don't eat. I have a little 12-year-old I've been working with for over about 50 days now, and I've gone, you know, doing due diligence with every rule out I could possibly do because this child, I know this sounds funny, but we're an eating disorder clinic, but this child will not eat real food. She wants to drink her supplements. She wants to use the tube. She will not eat real food. So we went from everything from phobia to trauma to anxiety and to pleasure. Does she get pleasure from food? So one of the things that we did was we brought out a bunch of candy because we heard, you know, through her parents that she would eat candy all day. And so we ruled out that, thought, well, maybe she doesn't taste food well like others. And they say that in anorexia, that those in that starvation mode, food does not taste good for them. And they're never going to enjoy food like the rest of us do. And so that may be a component of why they restrict, because it just doesn't give them pleasure. I thought that might be the case with this young lady, but I don't think so, because she does taste candy, she does taste food in the sense, and she will remark that, oh, this is salty, this is good. She will say things like that, but she just doesn't want to eat it. So at the end of the day, I realized this little girl, this little 12-year-old who hasn't grown in 4 years, has an eating disorder, and it's about power and control. Yeah, and you can imagine all the underlying issues with that. So there's so much to consider when you're diagnosing an eating disorder. It can get so muddled in so many other things that I think what we did for 45 days is pick apart, you know, what could this be? And sometimes at the end of the day, it's about power and control. You know, it's about getting their needs met. I would say it almost is, but sometimes you'll get a patient who maybe does have food phobia or phobia of swallowing, or does have a medical condition that can explain, you know, why they're not eating. But a lot of times it is the underlying issues. Family influences are obviously significant. You all know that, where you work. I don't have to go into that. Trauma. About 20 to 30% of our patients have some sort of trauma if you're looking at physical, sexual, and verbal abuse or neglect. If we look at a spectrum of trauma, they can range anywhere from bullying, you know, being teased at home, to bullying, to obviously the most severe, sexual. And cult kind of, you know, trauma. But I think what I see a lot of is bullying, bullying about weight. And often that will trigger, you know, someone, particularly if they're a little bit overweight as a child. We have a patient right now who was severely bullied about her weight. A little bit chubbier as a kid, and she just said at that point, I'll never be fat again, and she started restricting, and it's led her on a course of anorexia for over 6 years now. And I really believe that bullying about weight is not taken as seriously. It's starting to, because we're seeing some extreme behaviors or extreme responses to bullying, like these deaths that we've seen and suicide. But I think bullying about weight is still kind of socially acceptable, because it's, you know, we make comments about people's body size and weight all the time. You know, you're skinny. Oh, look how much weight she's gained. You know, even if that's not bullying, it's still kind of these comments that we always make about weight, that we just don't really realize the impact that they can have on the messages that we're sending kids. So. Then we have societal, cultural factors, society. You know, we all know, we don't have to just go to the grocery store and see all the thin, you know, coquettic women in their advertisements, and how they use sex and to sell. And that's something that we talk a lot about with the kids and our adults. You know, be aware, you know, of how what these messages are sending you, and how thinness is equated with love, acceptance, power. I just heard this morning, this is so off topic, but I don't care. This morning there was this guy, I don't know how old he was, 20, 21, and he said, I just heard it on the radio, I guess apparently he wanted to do an experiment. He said he dressed up as a famous person. Like, I guess he was in New York, he put a leather jacket on and glasses, and, you know, had designer jeans on, and he hired a camera crew, and he hired a photography crew, and he hired bodyguards. And he went down the street of Times Square, and he's walking down with these and they're taking pictures, and they're filming him, and he's got the bodyguards next to him, and people start coming up to him and asking for his autograph. And then they're interviewing people. Oh yeah, you know, have you heard of, you know, Joe Schmo before? And one guy's like, yeah, and this is a real live interview. Yeah, I've heard of him. I have his first album. He's nobody. He's never sang before in his life, and he goes, oh really, you have his first album? Did you like it? Yeah, I love his first single, it's awesome. I want to get his autograph. I mean, it's hysterical if you listen to the whole tape of him being interviewed, and it just is so, I think it's so, in fact, I'm going to try to get that tape and show it to the adolescents. I think it would be so, to look at how we glamorize celebrities, and how we put so much energy into valorizing these people, and they're nobody. And I don't know what that's about, but I think that it certainly speaks to the influences in our culture, and how it can be, we have a narrow definition of beauty, and we have a narrow definition of health. And I think we need to really look at that and challenge that. So, of course, we've got to have more to eating disorders than looking at a magazine, right? Because we all look at them, parents have dieted in our homes, and we all don't have eating disorders. So we know that there's more to it, but it's certainly an influence. So, and then we have, you know, high sports. We just finished off the Olympics. We know that there's a huge influence especially those sports that it's a lot about the body and how you look, and you know, the outfits. So of course, for example, 1 out of every 5 ballet dancers has an eating disorder, and we know that there's other risk factors or risk sports that put people at risk for eating disorders. It's interesting, there's a lot of research looking at, do these patients, what comes first, the chicken or the egg? Do they find these sports because there's this genetic influence, or this, you know, this predisposition to their body being thinner or leaner. Like, do they go into ballet because this, or does the ballet trigger them? You know, it's kind of interesting that they're looking at those dynamics right now in particular sports. So just quickly, you know, we have mood disorders in terms of the influence. I'd say about, this is a lot, kind of a integration of research. 40 to 70% struggle with a mood disorder. I'd say about 95% of our patients have at the intensive level, struggle with depression, major depressive disorder. We see a lot of bipolar. About 25 to 40% of anorexics struggle with OCD. There's a huge genetic component there, particularly the neurobiological component of anxiety and eating disorder. They say the pathways are very similar. And then we have other issues, PTSD, social phobia, substance abuse, 40 to 50, struggle with substance abuse, even in our adolescent population. And then about, like I mentioned, 30 to 40 patients with eating disorders have some trauma, some type of trauma. This is research from, and you may know much of this given your backgrounds, but just to quickly kind of go through, since I know a lot of our talk today is finding balance, looking at trauma and the comorbidity with eating disorders. We know, obviously, you know, I love when I say this, child sexual abuse is a risk factor for eating disorders. Well, it's a risk factor for a lot of things, obviously. But it's just check boxes. That's how I like to look at these. So I have a patient coming in and I'm doing an assessment. I look at these as check boxes, like, wow, they have this, they have that, they're displaying this, and I'm kind of thinking, this young lady's had trauma, you know. And so I don't obviously assume that, but I start putting together a picture when I start seeing the behaviors like self-injury, like chaotic home environment, substance abuse. And it just kind of puts together a picture for me that we have a child who is more at risk, who is more vulnerable, and has a prognosis, you know, that is not, I wouldn't say, I would say conservatively, we just have to know that we're going to have long-term care with this patient, and they're going to need a lot of different types of therapies. So the spectrum of trauma, obviously, like I mentioned, from bullying to extreme, it's more common in bulimia. Trauma is more common in bulimia. That doesn't mean it doesn't happen with those with anorexia. But if you look at the way we conceptualize, and this is so stereotyped, but what I've seen in my experience, bulimia, those patients have more erratic and chaotic emotional regulation issues. They're all over the place, from one end of the extreme to the other. And those with anorexia, it very much parallels their relationship with food. They're more controlled, they're over-controlled, I would say. They're more distant, they're more alexithymic, which is they're physically and emotionally cut off from their emotions, and they don't feel anything. We have a patient right now who's she has had trauma, but her response is, her trauma was her mother basically told her she wished she would have never had kids and left the house, left her. Very traumatic. So her response has been very much so over-controlled and so non-emotional, and that so much relates and parallels her relationship with food, which is restricting. And then those with bulimia are pretty much all over the place. So that's kind of our thing. We are finding more trauma. If you see men and boys who have eating disorders, the likelihood of trauma is increased than if you would with women, if you will. And so it's just something to consider. Men and boys, they find that a lot of what triggers their eating disorder is bullying. You know, I mean, it triggers girls as well, but if they're bullied, they're more likely to respond more extreme. And then also father issues. If their father has had health issues, it seems to be a risk factor for boys and men to develop an eating disorder. So there's something interesting from the research. Multiple episodes of trauma, obviously, so it's not just one incident. They tend to have multiple issues with trauma, kind of that vulnerability, that, what's the word, when they kind of are really seeking, it's that codependency that Stephanie will talk about. And so they often put themselves, or because of their lack of skills, get themselves in situations where they can't protect themselves. Trauma is not necessarily associated with greater eating disorder severity, so that's interesting to know. And then, of course, we're looking at when we have trauma, all the comorbid issues that go along with it. They say that in order for those with eating disorders to get well, obviously, like Mike said this morning, you have to address the trauma and the PTSD that accompanies it. And so, obviously, that's what we're doing. We have one girl right now who's going through EMDR at our inpatient level and has made remarkable progress. It has been really, really cool to see. So, and that's research from Timothy Brewerton. He's one of our faculties that is part of our Rosewood Institute. Really kind of cool. As I started off, we talked about multidisciplinary approach, which is indicative of the illness itself, being it's biological, it's their psychological, their social, there's, I would even go to say spiritual. So in addition to having a medical doctor on the team, we have a dietitian, we have psychiatrists, we also have our therapists, and then other ancillary. We're lucky to do equine and art therapy, but as far as outpatient, the four are definitely, medical, psychological, psychiatrically, and then other forms of therapy group is priority. And then we do anything from, the evidence-based treatment for eating disorders at this point is CBT, DBT, and they're showing more research with the EMDR as well. So that's kind of cool. Our levels of care, we've already kind of talked about that. They range from most intensive, least restrictive, if you will, to most intensive. We are not acute medical ICU at Rosewood at the ranch, but there are facilities like in Denver, it's called acute, where they take patients so ill you wouldn't even imagine. 50% of their ideal body weight, 49% of their ideal body weight, and get them stabilized and then send them to more of an intensive hospitalization program. So there is two facilities in our country that actually do force feeding, but I think only two, and it's on an extreme level. So it's very hard to get, especially an adult, who is refusing treatment into treatment because of the whole ethical issue of they have a right to, their own decisions, and oftentimes they have to get a guardianship. We've had several patients with anorexia particularly have to have guardianship to get them into treatment and require them to get fed. So it's tricky. It's very tricky. So, okay, any questions about that so far? Just to kind of give you an overview.
I have a question.
Sure.
Just on the one that you said about boys, and usually their fathers have a medical issue?
Yeah, like a heart attack or diabetes or some type of consequence of their health. It often, what they found in the research, triggers the child itself to want to be healthier, to not want to, be like their father in that sense. And so they say that has been a commonality that they found in the research when looking at men and boys, that fathers have had health issues.
Okay.
Mm-hmm.
Thanks.
Sure. Anything else? Okay, I'll turn it over to Stephanie. Did I take too much time?
I don't even know what time it is. I'm actually going to have to talk.
We're good because we really have until like 10:30. So you have, yeah, very good.
I can't do anything without my clock.
I know.
To the degree that our clients will hide it from me.
Yeah.
And make fun of
Oh,
me.
it is like a
Or they'll change
clock.
the time
They'll change.
and be like, oh, I don't know how that happened. Hi. So, before I get into this, I want to check in with you guys and see why this training interested you. Like, what are you seeing with the populations that you are working with? And what are you hoping to really learn? Anyone?
Yeah. Well, I'm not currently working, but I have a family member who has anorexia nervosa, and she's in treatment now, but it's not going anywhere. She's been in treatment for a while, and it seems to me that they're not getting to a lot of these underlying issues that you're talking about. So this was interesting to me because I don't know a lot about eating disorders, and I'm more interested to get a better understanding of what's going on with her, so that I can be more supportive.
Absolutely. Yeah, very common. Anyone else?
I think in THS, I think we would benefit from being able to assess for disordered eating more since we work with trauma so much. So.
Absolutely. Okay.
I think for me, as a director of outpatient, we don't really have anyone who specializes in eating disorders. So hopefully we'll be moving more towards that, where we can get someone who works more with people who understands eating disorders more.
Yeah.
So it's good to have this information and be able to
That's really good to
take back
hear.
and get them, start getting people hopefully trained or looking for different opportunities to send people to training so they can learn more.
Great. We're gonna be doing this every month, so, yeah.
With the Crisis Navigator program, we're getting a lot of referrals, and I'm working with a client right now who has been or is anorexic. I really wanted to know an awful lot more about it. And they all, most of our clients do all seem to have underlying trauma issues.
Yep. Yeah, I kind of look at it as the eating, for those that develop eating disorders, it is only one of many possibilities of how a person learns to cope with trauma. I mean, very simply put, that's kind of what the function of the eating disorder is. You know, it's a coping mechanism. I'm going to skip over here. And anyone familiar with PMLD?
Just the name.
Just the name?
She's in Wickenburg.
Yeah. She's at the Meadows.
Yeah, right, at the Meadows, yeah.
She's one of their, she even created the Meadows, I don't even know. But I've seen her train and she's fantastic, very quirky. Okay, good, I did it right. So what I'm going to teach you guys today is essentially Rosewood. We've sort of adopted this model as a way of conceptualizing our clients as a whole. And so we actually teach this to our clients on a regular basis. This is one of our recurring lectures that we do in group so that they have a better understanding of what they're experiencing, because it really explains a lot of their world. And when they hear this, they don't feel as crazy. You know, some of them go, I just don't know what's going on, I feel crazy. Anyone heard that? In your you know, and so there's a reason for that. And so the metaphor of the tree is really helpful, especially for those that work with metaphors and need that picture to really understand. But essentially what you're looking at here is the branches. These reflect all of the outward behaviors and the things that bring people in to get help. So it can, as you can see, it's not just eating disorders, it's all addictions. And so these are the things that get out of control in their life that very often the most common reason that someone seeks help has something to do with relationships. So even if maybe they have an eating disorder or they are an alcoholic or abusing drugs or anything like that, the reason they go to treatment is because someone has expressed concern or a relationship with a loved one is spiraling out of control. Like that's what really motivates people to go to treatment. And so this just gives you a brief example of the different types of things that might also be out of control, not just the relationship. For a lot of our clients, sex addiction is huge, especially as they start treating the eating disorder and they lower those behaviors, you'll inevitably start to see something else bloom. They'll start wanting to do something else to cope that is dysfunctional. We call that addiction switching. You guys see that? Yeah. So shopping, food obviously, drugs, alcohol, gambling, all those kinds of things. Shopping addiction is huge because a lot of our clients go, well, that's no big deal, especially if they have money, you know, and it doesn't maybe cause a financial hardship, but for a lot of them it does, but yet they continue. And so we kind of see all of this when people come in. Like Dena said, there's so much comorbidity with different addictions that it's very rare, honestly, and maybe you guys can speak to this, that we get someone who just has an eating disorder. So we really treat multiple addictions at once. And the reason this is called the Coda tree is because how the theory goes is that all of these behaviors are created by the trunk, which is codependency. And how we define codependency, how I've come to simply, because it's kind of a concept, but how I define it is the inability for a person to esteem themselves based on the concept of inherent worth. So instead, they esteem the inability to esteem oneself based on the concept of inherent worth. So in other words, I'm worthless. I only feel my worth if I, in our population, exercise after I eat, or go purge, or don't eat, you know, those kinds of things. For our bingers, it might look like they seek worth through being needed. That's a really common one, you know. And so our clients have such, many of them have such broken ego strength. They just don't have that inner strength to kind of stand up on their own emotional 2 feet, so to speak, because they do not believe in themselves. And codependency, the core issues that happen because of that inability to esteem oneself are listed over here. Obviously, low self-esteem. That's kind of a no-brainer. Boundaries. And here, we look at the spectrum of boundaries, and we're going to get a little bit more into it. But essentially, what we teach them is codependency, in terms of boundary violations, can look either like being overly dependent or completely not dependent at all, which we call anti-dependent. And so you've got the whole range where it's either I can't do anything on my own, and that learned helplessness that happens, or I don't need anyone, I'm going to do everything on my own, and rejecting all forms of support, human connection, and so on and so forth. And both are equally devastating. Okay. Reality, meaning that one's reality is distorted through the eating disorder filter. I mean, just looking at body image, that's a very clear example of a reality distortion. You've got the body dysmorphia happening, you know, truly just not seeing reality when they look in the mirror. But that comes up in relationships, misperceptions of what's being said by others, all kinds of ways that this comes up, reality distortions. Dependency, linked with boundaries there. Again, that inability to be in the middle, interdependent. You know, either overly dependent, not dependent at all, kind of a thing. For those of you that know DBT, that's that dialectic of active passivity and apparent competence. That's really what that is. And then the final one is containment, and this is something, if you see our rules up here. Number 2, respect, mindfulness, and containment. And so what we ask our clients to do in group is to be very aware of things like if their emotions are spinning out of control, to try and contain them in a manner, and this is what we're going to talk about today, is how to do that and how we teach them to do that. But on the other side of that, again, because everything's a spectrum, is the over-control that Dena referenced. People who disconnect in group and don't feel anything at all. Again, equally devastating to the chaos of too much emotion. So that's one example of containment. It's also containment of topics. Like here during dinners and things, we ask them not to talk about eating disorder behaviors, exercise, even treatment, you know. Keep it neutral, kind of a thing. And that's because it's learning to contain what's coming out of their mouth, you know, that respect for their peers and themselves. So these are the core issues that we really look at in terms of codependency. And boy, do we see these active in our groups. And once you guys start looking, if any of you run groups, I know you guys do, you'll see it. It's just like a beacon. Like, woo, look at that codependency. You got the rescuers. I always joke that groups run better when we have codependent people in them because they take care of everyone else and it makes my job easier. But again, that's not helping them because they're just living in their codependency. So the final piece of it, the roots of the tree, are trauma. And how we define trauma here really opens it up. Anything less than nurturing or experienced as shaming. And so you hear that definition and it really opens up what can fit into that category. And it's so important that our clients understand that because a lot of them, I would say, and this is not based on research, this is just my own head, that like 50% of our population has some pretty overt trauma. Like it's clear, part of our groups we have them share their life story, and so you'll hear sexual abuse, all the big T's, you know, But then the other 50% walks in going, I have no idea why I have an eating disorder. I have a good life, I have a good family, my parents loved me, what's going on? And they really don't know what is wrong. And often, very often, it boils down to anything less than nurturing or experienced as shaming. Either they've gone through a lot of things that they're minimizing, that they don't count as trauma because it's not sexual abuse, not to minimize those things, but they do it, you know, and they sit and they compare their story. Well, I just think my life story is going to be boring because I don't have all of this crazy stuff that happened to me. Not the case, you know, there's always something. We've all experienced trauma. And the nice thing about trauma is that it's subjective. It doesn't really matter if someone else would call what you went through trauma. If you experienced it as shaming and traumatic, it's trauma. And so that's what we really teach them, to normalize and to help them gain some awareness of what in their past has, in fact, impacted them. The other piece of this that very often, with that 50% that doesn't know why they have an eating disorder, is that they've got a lot of attachment, unmet needs, coming from family of origin, that they really aren't aware of at first. Sometimes I feel a little sadistic because when they start gaining awareness of some of the brokenness that's actually maybe in their family of origin, when they had this sort of fantasy that everything was wonderful, it's a little bit heartbreaking. But then they can start to heal because that lack of awareness is blocking them. So the important thing to understand about this is the link. Trauma creates codependency, which fuels addictive behavior. And what I also explained to them is that codependency is us trying to get our needs met in a dysfunctional way, but it works. And that's why it's self-reinforcing. It gets our needs met. And so part of treatment is learning how to get your needs met in a functional way. Okay? So, down there in those roots, deprivation, abuse, neglect, abandonment, lack of attachment, over-attachment, you know, enmeshment with parents and such. And if you do not heal, this might be self-explanatory, but if clients don't heal that trauma, they will keep the revolving treatment door going, back and around and around and around. And what Dena referenced with the insurance earlier, it's really heartbreaking because eating disorder treatment is expensive. And if insurance, you know, they have a very different view of what treatment means and what healing means and recovery. And if they kick them out prematurely, it's a setup, you know? And it's really sad because it happens all the time because people just don't have the financial resources to really continue the treatment process to the extent that they need. So that's my little soapbox on insurance. I'm both grateful for insurance and I hate it.
And I think that probably, it extends outside of eating disorders too.
Absolutely.
It's just, whether you're SMI, gentleman health, or,
yeah. Yeah, it's so sad. And I came from THS where we didn't deal with insurance, so this was a rude awakening to me when I got here. And it upsets me. Maybe I'll become a lobbyist. Next page. I'm really hot. I get hot when I talk.
Is it hot in here? You guys okay?
Okay, because
I do this.
I
when
was
run
too,
meetings,
but
I'm like,
I'm thinking hormones, but wait, it's too much information.
all right, so what this is referencing is basically, and this is kind of self-explanatory and a little bit like, oh yeah, that makes sense. These are the pieces of us that make us human. This is all part of being human. We have a physical being, we have our body, mind, feeling, spirit, social interaction with the world, and sexuality, okay? And each of these pieces of ourself, so to speak, are all interdependent of one another, okay? Meaning that they're connected and related, but they're separate aspects of ourself, okay? And each of them also represents needs. And the greater the difference between what we needed and what we actually got, the greater the dysfunction that you'll see. And so let's just look at them one by one. Our physical needs, this is kind of typical Maslow here. We've got that need for food, shelter, warmth, perception, and the 5 senses. If all of those are met, then we're going to be more connected to our body. If not, we're going to learn how to detach from that body. And this is where a lot of self-hatred, learning my body doesn't deserve. I mean, you'd be astounded the number of people that we hear say, I don't deserve food. And there's a number of reasons why someone might develop that belief.
What do you mean by perception?
That's just one of our physical, like that's what we do. We perceive everything. You know, there's a certain way that we perceive things. And when these basic needs aren't met, food, shelter, warmth, etc., our perception gets distorted. Okay? So that's what that's referencing. It's essentially, with all of these, if these things are met, then those are going to be intact, and if not, they're going to be distorted. Does that make sense?
Yeah.
And so with like our mind, the mental need for growth, to have our reality validated. How many of our clients grew up in completely invalidating environments? You know, all of mine. I think, can't think of a single one that's like, oh, my parents were always perfectly loving and validating. Some of them try to say that, but again, then they learn otherwise. And so when that doesn't happen, we disrespect ourselves. Okay? When it does, that's how self-respect is learned from a very young age. That is a need, to have that self-respect. With emotions, you know, when we have love, respect, and acceptance, then we're able to connect with our feelings, and not, for some people, it's hate them. A lot of our clients hate their emotions. Like, they look at them as enemies, kind of a thing. And it's because they were never given love, respect, and acceptance, so they don't even know how to do that for themselves. That's part of what we're teaching them. With spiritual, freedom of choice and higher power. I mean, that, I think, is pretty self-explanatory, but essentially, I love the freedom of choice part because that doesn't happen in so many ways in our clients' lives. They don't get to choose, or they didn't get to choose. And that's such a spiritual concept, that sort of freedom of will. And so learning how to give that to themselves is part of treatment, you know, so that they can fully embrace their spirit self. Social, belonging and fun and interaction with the world. We've got both extremes there. And I think, and again, this is not based on research, but my own, what Dena said about the difference between the bulimics and the anorexics in terms of how they experience emotions, it's the same with relationships. What I have seen is that our bingers and especially the bulimics, they're very passionate people. There's a lot of passion sort of unbridled there. And I always talk with them about that as a strength. That passion is a strength, and I love that, you know, but it's, let's contain it. Contain it and channel it well. But they're always social. They're out having fun, they're out partying on the weekends, even though they're not supposed to be drinking in treatment, you know, all of that. Whereas our anorexics tend to really isolate themselves from the world. Like, disconnect, just like they're disconnected from their emotions, just like they're disconnected from their body. And so, with a lot of my clients, a huge goal is get a support network, make friends, you know, basic stuff. Because without that, it almost, in a sense, makes it meaningless. You know, we need community, we need clan. We're not meant to be alone.
Do you know why there's that big discrepancy between the anorexia and the bulimia in terms of the interaction with the world?
And if you guys want to chime in on this, feel free, but what I think it is the genetic piece. I think there's personality differences that sort of lead people in either direction. And I just think they have different personalities, just sort of in that genetic coding, you know? And so then when it's reinforced in the sense of an anorexic who maybe is a little OCD or a lot OCD, that reinforces disconnection, it reinforces ritual and rigidity and inflexibility, which translates into lack of relationships. A lot of them can't tolerate the imperfection of humanity, you know?
There's also a large fear of judgment.
Yes.
You know, because
That's
it's what
true
they
too.
feel about themselves. They won't socially interact with others because they perceive that that person is gonna judge them a certain way. So they will completely not interact due to this perceived judgment of something that's not even occurred yet. So,
This is Christina, by the way.
Yeah,
She's my co-therapist for another week.
And they're also, I think you mentioned just the body's response to starvation. You know, as we know through just historically, you know, they're in survivor mode. So to physiologically be cut off from emotions is the response to starvation. So in order to survive, I mean, if you think back on, you know, Holocaust days, you know, that was part of the body work to get them through that period. You know.
And one of our current clients is popping into my mind right now. He's a perfect example. He was here a year ago, and when he started at inpatient, he went through all the levels of care. When he started at inpatient, I think he admitted at 102, a weight of 102. He's about 5'9", 5'8". And when he got to us, he went through inpatient, partial, and came down to IOP. He was in IOP for about 5 months, probably not that long, 3 months. He weighed 167. Went home, did not continue with any aftercare, which is absolutely vital for them to do for 2 to 4 years after being in intensive treatment. If they don't do that, they relapse. I've not seen anyone who hasn't. And so that's what he did, and now he's back. And when he was here a year ago, he, his personality was just sparkly. You know, if a guy can be sparkly, he was. I mean, so funny and energetic, and he loved life, and he loved people, and he would sit in sessions and talk about how much he loved his peers, and how much he just, wow, I just didn't know friendship could be like this, and da-da-da-da-da, and he's back now, and he's lost 50 pounds in the last year, and he is a different person. His brain is not functioning, he is angry, and he is sad. I mean, he never cried a year ago. He cries all the time now. So depressed, he's the first person I've really seen the startling difference when someone fully relapses. And so, because I've only been in this particular field for 2 years, and it's just heartbreaking. And so this is an area where I see it glaringly with him. Really all of these, but it really, knowing how he was with all of his friends a year ago and how he is now, I'm just going, who are you, you know? So that starvation is just, it changes you. It changes your personality, you know, and it's really sad. And so then it's self-reinforcing again to stay disconnected because they're not enjoying themselves, you know, or they think people don't like me, or the fear of judgment that Christina mentioned. And the sexual piece is something that when we talk about it, our clients giggle. Our average age is probably 22 in our IOP, so they crack up and, you know, whatever. But the importance of knowing that we're all sexual beings, and with that relationship and interdependence piece, you know, in romantic relationships, when that's not met in an appropriate way, you know, if there's abuse or if there's, who knows what else could disturb relational dynamics, that sexuality, that's a huge one that gets very stifled. And I remember we just did a needs group recently where they were taught basic needs, and they identified their most secret need that is not met. And I think 5 of the 10 women that were there that night said sexual. They were like, wow, I didn't realize that was a need, you know? It is. And just how, just like anything else, it gets so stifled, and they're just not living. And so, not honoring oneself. So like I said, the bigger the difference between what you needed and what you actually got, and that continues in adulthood as well, the bigger the dysfunction. Okay? Any questions about that so far? Let's flip. Well, I'm flipping. And so, this is pretty self-explanatory, but the eating disorder and any other addictions separate out the parts of the self. Very disconnected and discombobulated from one another. And in eating disorder treatment especially, no matter what type of disorder they have, pretty much by and large they are disconnected from their body. And so in groups we're constantly like, they make fun of us. Stop asking me where I feel it in my body, you know, but getting them to identify what they're feeling and where is a huge skill that they don't have. And so it seems so simple, but it's not. It's scary to a lot of them. You know, for them to actually sit with their bodies long enough to identify where they're feeling it is a really scary thing. They want to crawl out of their skin, you know, because they're so uncomfortable with their bodies. So, you know, we teach DBT here and a lot of other skills to help them manage, especially the feelings and the thoughts, you know, because their thoughts race. I don't think we have a single client right now that isn't like spinning all the time. And so just, you know, containing, it's like internal containment of thoughts and feelings is a huge part of it. And so, goal of treatment is to pull all those together, okay? Be able to experience them. Another little schematic here that helps illustrate that. This is supposed to be a person, which makes me laugh because it looks like a star. But there's no particular rhyme or reason to where all of these different parts are placed, except for body being on the outer, obviously, because that's our vessel. But this is just to illustrate the need for reintegrating all of those aspects of self, reconnecting with all of those pieces of yourself in order to heal and recover and live a life worth living.
I just have to add to that, a lot of times with our clients, I use the example of when you fall asleep on your arm and your arm is super numb. So that's what they come in, just numb to all of these things. And through treatment, they go through the process of the blood rushing back to your hand. It's really uncomfortable. It's really foreign. The hand's kind of not functioning, but it's getting there. And then by the end of everything, they get to the functional place where your hand can be used again. And they can start living their lives and progressing forward. So that's a good little...
That's why I'm going to miss you. You come up with wonderful illustrations. Yeah, that's a great way of looking at it. Mm-hmm. And the key here is that in order to reintegrate, clients have to stop their addictive behaviors, all of them. If they are using any kind of addictive behavior as a way of coping, it's not going to work because it blocks. It serves that purpose of numbing or controlling. A lot of them it's about control, like Dena mentioned. And they've got to just, we talk about surrendering all the time. The I trust the process little affirmation here, that's what it's really about. Like when people come in here, they're broken, life is out of control, no matter what level of care. And they have to learn how to let go of that control and surrender that we know that we care about them and that we know what's going to help them. And that's really hard for someone to do. That's hard for me to do, you know? I often think, man, if I were a client, I think I'd be a nightmare. Because, you know, I'm one of those people that's like, you need to explain to me why you're asking me to do this, because I'm not just going to do it because you tell me to, you know? And so they get a little anxious sometimes when we're asking them to do things they don't want to do. And so, yeah, you've got to stop those behaviors. And, or at the very least, not be using them consistently as a way of coping with life, okay? So when they first get here, going back to the tree, again, no matter what level of care they're entering into, everything that's happening in those branches, all of those behaviors, that's the first part of treatment, is stabilizing that before we start getting into that deeper stuff. And I actually really love that I'm working here at this level of care, because once they get here, if they've started at a higher level, their body is restored more often than not. They're able to think, and we get to really do some good work. You know, like, whereas I think sometimes up at inpatient, the whole focus is on, let's get your body healthy. And they can do some work, and I might be vastly overgeneralizing here, Dena, so you can correct me if I'm wrong, but you know, I think that a lot of times once they get here, we're able to really dive in, and it's so cool, because they can start seeing the freedom that they can have, you know? So, all right. Anyone not know the term ego states? Make sure everyone's on board with what that means. Okay. When a person has really any addiction, for the sake of what we're talking about here, eating disorder, they develop, from an early age usually, these two different ego states, the wounded inner child and the adaptive defended adolescent. And these are types of behaviors that you will see come alive in your sessions and in groups and all kinds of things. And the wounded inner child is exactly what it sounds like, okay? This is an inner ego state. We've all got that inner kid in us, you know? We've all got wounds. And when that gets triggered, our clients will go what we call less than. They become extremely shame-based. They start thinking of themselves as terrible, awful, bad. You know, we talk about toxic shame a lot and how that gives the message of I am bad. Just deep down in their core, you can sense that they feel that they are bad people. And a lot of times we'll ask, it just happened last night in group, how old do you feel right now? 7. You know, and they can tell once they've been taught this lingo, they can start to tell when their inner child is getting triggered. And they can usually pinpoint, yeah, I feel about 14. Adolescent, you know, or whatever. So, what the wounded inner child will look like is lack of emotional containment. This is when you're going to have people in puddles on the floor, crying, talking about how horrible they are. They are just in their shame. And with eating disorders, there is always a core of toxic shame that has to be addressed and healed. And they feel bad, they feel rebellious, they're very, very dependent. So this might look like a client who constantly is calling me whenever something bad happens in life, you know. Oh my gosh, I don't know how to handle this. Starts to burn you out after a while, you know. But that's where this is coming from. It's triggered by that wounded child. Feels very out of control and emotionally chaotic. And the emotional energy when this ego state gets triggered is 8 to 10. Really intense, okay? Usually, what I've seen is that this is going to be a pendulum swing, and it starts always with a trigger that is about their shame. In order to protect themselves, I do this, by the way, they pendulum and they swing over to the adaptive defended adolescent as a defense mechanism. And this is a client who goes what we call better than. How do teenagers act? They totally think that they're like the bomb and everyone else is stupid, right? That's what this looks like. You know, that is exactly what this looks like. And we see it a lot whenever we maybe are having a conversation with a client about some areas where they're not maybe following their meal plan or you know, behaviors that we're seeing in group that are disruptive, and woo, they will just go like, yeah, well, you know, and the attitude and whatever. And so it's a lot more comfortable to be here than there. They feel much more in control when they are able to be adapted. Think about how awesome you felt as a teenager. Like, I felt really powerful, you know, most of the time. I was just like, I am invincible, everything is wonderful. And so that's what happens when they pendulum from the wounded inner child into the adolescent, and that's why it happens. Because it's a very finely constructed defense mechanism. And with the wounded child, they lack boundaries. Everything's flooding. For those of you that do EMDR, if a client floods, that's what's happening. That's getting tapped into. And they can't manage all the feelings and in some cases the flashbacks and those sorts of things, and they go into shame, okay? And then they'll close back up. And here in the adapted adolescent, the boundaries are very high and rigid. Nobody's getting in, and I'm not getting out, okay? They feel invulnerable. They feel like they are good and perfect. They don't need anything. They don't want anything. I am fine. This is your fault. You start getting blamed for whatever. This just happened in group. Last night, one of my clients went off about how she's just panicky all the time and she's not getting better, and she's like glaring at me. You know, like, it's my fault that she's not getting better, even though she's not doing her homework. You know, like those kinds of things. That's the adapted adolescent. The need to control others and point the finger and blame shift in order to lessen, it's all to lessen that shame. Okay, that's really where it's coming from. So when they're in this place, it can be really easy to get really mad at them because they're being jerks. You know, But if you have that understanding of where it's really coming from, and that it is a defense mechanism, it's a lot easier to find that empathy when you're working with them. And let me see if I'm missing anything here. No, not there. So with our adults, and we teach this to our adolescents as well, but what Allison is our therapist that runs the adolescent program, and what she talks with them about is, okay, you guys aren't adults yet, but you can have a functional adolescent, you know, and she teaches them kind of the same principles as a way of helping them grow up, you know, like, and so here's what the functional adult is. It's that emotional energy of 1 to 3, so it's a lower emotional energy where you feel the same as. You don't feel less than someone, you don't feel better than someone. Everybody's equal, kind of a thing. You've got an intact boundary system. You take responsibility for your reality. Okay, so you're aware of your distortions that might be coming into play. A lot of our clients, we teach them to do what we call reality checks. So if they are living in their distortions in group, you know, sometimes we'll prompt them, like, do you need to get a reality check right now? Because they go all kinds of crazy places. And they will. They'll ask their peers, okay, here's what I'm thinking. What do you guys think? And it helps because they'll get reality. They'll get reality reflected back instead of their distortion. And they're able to let it go. Interdependence, so the ability to ask for help when needed and stand on your own 2 feet when you can't. Both. Not overly dependent, not completely anti-dependent. And there's a self-control, which goes along with containment and moderation. You know, we teach them all things in moderation. And the box at the bottom, I have a slide here in a little bit that's going to go into more detail, but what this just basically reflects is the need to create more flexible boundary systems. So what happens is a lot of people get trapped in the pendulum swing, back and forth, back and forth, back and forth, and they don't know how to stop. And this is when they start feeling crazy, you know? I go from totally emotional to everybody sucks to you know, it's just like, think of living that way, you know? And so what they're learning to do is really slow down that swing, and formulate their boundaries in a different way. That's so important. And so that's all I'm going to say about that for right now, because we're going to get to more about it in a second. Well, before we go there, does this all make sense?
What was the box again?
The box represents the boundary system, and we're going to get to more details about that in just a second. So basically, lacking boundaries on wounded child, too rigid boundaries on adaptive adolescent, and the functional adult has flexible boundaries. Okay? So here's where we get into some of the tools. For the wounded inner child, now here's what you can teach your clients to do. This is what we try to teach ours to do. A lot of them are very, as we've kind of talked about, rejecting of their emotions. When their emotions are really, really intense, that's why they swing into adaptive, because they are rejecting what that emotion actually means. They want to avoid really looking at why they just got triggered, because there's a reason. You know, nobody likes to sit in their shame. That hurts. And so, the ability to give themselves permission to feel and tolerate that extreme emotional energy. DBT is great for that. A lot of the skills taught in DBT, you know, are going to help with that kind of thing. We'll sit in group and, you know, sometimes it's really obvious when someone goes wounded, and they'll just get lots of support to just sit with it. You know, let it come down on its own. Talk about it. There's a lot of different ways. It's that acceptance of the emotion. Identify any negative messages that they're buying into, like I'm bad, I'm worthless. So core beliefs. We're talking about core belief work here. Hugely important. Sometimes when you get to know someone really well, you can just look at their face and know what core belief just went through their head. You know, it's obvious in their body language, and some of them turn red. I mean, it's so powerful. Because remember, with wounded child, it's that emotional intensity of 8 to 10. Resolving the trauma issues, doing grief work. There's a lot of grief with addiction. Grief because of what the addiction takes from them, grief because of what the addiction does to their mind, shattered families. I mean, there's all kinds of grief work involved in working with eating disorders. And that's part of the trauma. Now remember, can't get to the trauma until they've stopped the behaviors. So that's the really key part. And if you've got a client who is continuing in their behaviors, they can't do that trauma work yet. That's got to be stabilized. And nurture self. Woo, do they avoid that? At the end of every night, we ask them what they're going to do to like self-nurture, or if they're struggling, cope for that night. It's almost amusing how many of them look at me like, oh, you're really asking me that again. You know, they don't like to think about it. They don't like, for a lot of them it triggers the sense of being unworthy. Unworthy of being taken care of. And so it's so important for them to learn to do that, and that's why we ask every night. Make an inner commitment to yourself to go do that. With the adapted defended adolescent, if you notice that someone's in that mode, so if they're mad at you or mad at someone else, you know, and they're like, ah, have them identify the defense mechanisms and the distortions, cognitive distortions that they are buying into. Pretty simple, basic stuff, you know, but so powerful when used correctly. Recognizing triggers. What am I being reminded of in my woundedness? All right, why am I going adapted? And once the clients know this lingo, they get okay, they get better at calling themselves out on it. You know, like, oh yeah, I am going adapted. I wonder why. And then they get into curiosity, which de-escalates the emotion, you know? So, here's the next thing about the boundary system. Essentially, this is a model of how to help them learn how to create better internal and external boundaries using affirmations. And the huge part of that is having them go, who am I not? What am I believing right now that's not true of me? So again, with the wounded and the adapted, very simply put, wounded believes I am bad, adapted believes you are bad. Wounded's about me, adapted's about everyone else. Okay? So if you're hearing themes in either of those areas, you know that their boundary systems are not functioning at an adult place. Okay? And so these are all just examples of different types of affirmations that can help them sort of shore up those inner boundaries. And the internal emotional boundary helps to protect and contain the emotional energy that they experience. The external physical boundary protects and contains their physical energy. Okay? And so this one's highlighted because I think it's such an important one with eating disorders. My feelings will not kill me, but ignoring them will. I had someone ask me the other day when I did this lecture, how? They always want to know how. How, you know, and that's when you start getting into stress effects on the body, you know, the fact that when you get angry, your body doesn't recover from that for at least an hour and a half. And all of the different interconnection between body, mind, spirit, you know. And the fact of the matter is that with anorexia, that's what it's built on. I want to ignore all of this. I want to avoid all of this. And it literally will kill them. Because they're avoiding something deep. So, does that make more sense, the box now? Okay. Any questions about that part?
Maybe we're going to get to this, so tell me if I'm jumping ahead, but when I think about some of the kids that are under 18 coming in for treatment, many of them still live in dysfunctional families and parents. And do you incorporate parenting nights or family counseling with your IOP?
Definitely. We have, with our adolescent program, we do every other week a support, like family and friends support group on a night when the kids aren't here. So it's a different night, right? No, they're here. They're here for dietary. Yeah, that's right. Never mind. That would make more sense because then they don't have to be at home alone. And so we do that, and yes, we definitely are huge on family therapy here. Like, especially with the kids, because if they're still living in it and it is dysfunctional, they're gonna just relapse over and over and over again. Because that's why they have an eating disorder, You know what I mean?
Right.
So yeah, that work is vital. And so we do it as much as we can with the adults, and we do have a family and friends support group for the adults as well.
Okay.
So both are every other week. All right. Last page. More tools to teach. Slightly reminiscent of the one we just went over, but a little bit more detailed. In order to help clients reduce emotional energy, again, that permission to feel is vital. No wrong feelings. Feelings are human. Battling those myths that they all have built up about what emotions mean about them. You know, not okay to cry. All the big common ones that I'm sure a lot of you hear a lot. Crying is weakness. Those sorts of things. I just heard it last night. Someone said it. Building tolerance. Let yourself have the emotion and allow it to pass through the body. Grounding skills. Huge. Grounding for when they're spinning and coming back. A lot of dissociation happens in our groups. Identify the message. So again, having them learn to tell, am I going wounded? Am I going adapted? Okay, so that they can start learning how to battle that themselves and not totally buy into those messages. Affirm or reframe to functional esteem. Choose what you want to believe about yourself. That's huge. This is part of why we have all these affirmations on the walls. We have them say an affirmation at dinner, before dinner and after dinner every night. It's part of it. Creating some of those boundary systems. We try to challenge them to really choose something that's relevant so that they can really say it to themselves. They don't always do that. It becomes rote after a while. Nurturing self and shoring up your boundaries. That's how they find that functional adult. Okay? And finally, convert to the gift. And I'm going to pass out a handout that gives sort of the 8 basic emotions and what their gifts are, because I just think it's really helpful. Take one and pass it around. So if you look as it comes around, this will help with identifying. If people can learn to identify the good thing that this emotion is giving to them, it makes it a lot easier to tolerate and accept. If they can identify, okay, what is the purpose, basically the function of this emotion in my life right now? And so if you look at anger there, and it gives you a couple more words, assertiveness, strength, and energy. You know, fear, preservation, wisdom, and protection. Pain, healing, growth, and awareness. Joy, abundance, happiness, and gratitude. Passion, appetite, energy, and excitement. Love, connection, life, and spirituality. Shame, this is the one they struggle with. They're like, what in the world does shame do for me? Because all they know is toxic. But healthy shame gives humility, containment, and humanity. Okay? And guilt, values, amends, and containment. So, that helps them to identify what they can learn from that emotion, how they can connect to it, how they can be powerful in it by connecting with one of these gifts. And it helps them connect to their values. So, I think that's all I have for you today. Any questions?
I'm interested in using this with the THS sexual assault group. Do you have any resources for where I can find like handouts or a book more about this?
Pia Melody wrote multiple books. Facing Codependence. She wrote one called Love Addiction, Love Avoidance, which we didn't even touch on today. That'll be another lecture. She also actually does an intensive training called post-inductive training. And I think it's like a 5-day thing if they're still doing it, which I would actually really love to do. That really goes in depth, obviously, about how to use this with clients. So I would suggest looking that up. I think you can find it on the Meadows website. But there's a lot of things you can do in groups with this. You know, you can even take just one slide at a time and do a brief little psychoed and then processing around. You know what I mean? I've done it that way as well. Like really go in more depth with different things. Any other questions? Anything unclear? Well, I hope that this is helpful for you guys in working with your clients, giving you some real tools that you can use when you're sitting with someone and you start to recognize the pendulum, you know. What's next?
Well, we could talk a little bit about what this room is used for, and then they can kind of just, look at the offices and kind of see where we do the different, I mean, this is it. I was gonna take you through.
It's pretty small.
This is the east wing, this is the west wing. Wait, where are we? No. North, south, but I think, this part, obviously this partitions, and then we do a dining table here, and they come in and do their meals and snacks. And I think, occasionally, once a week, once a month, we take them out to restaurants.
Once a week.
Yeah.
Yep.
And
Wednesday night is dietary night. They all hate it.
Yeah.
Yeah.
And then they partition off, and then this part becomes our group room. And then we have
The
the
whole
kitchen.
thing is we use it for groups, just depending on what we're doing. Yeah.
But you feel free to look around, or just, the group room, and then we have a nice room in the middle there for meditation and groups.
Our lobby is right here, which sometimes it can double as a group room. But we have so many groups going on at once, and like parents are here, and we're pretty crammed.
Yeah, we also have an EDA group on Thursdays. It's in our lobby.
So feel free to look, just get up, look around the kitchen. I mean, it's mainly office buildings, but it is nicely decorated, and there's nice space. So,
Yeah.
Good. Any other questions? I need you to do one thing before you leave. And I forgot to have you do this. If you could, oh shoot, I should have had you do this as we go along, but I'll pass out both of them. Starting on each side. If you could just sign in, please. And then we're going to hand out certificates. And if you would also fill out your evaluation form, please. And any feedback you would have, we'd greatly appreciate it, as you are our guinea pigs, right? Because you're the first. Any feedback for more topics, time. We don't really have a choice on location, so. But anything you want to add, we really would appreciate your feedback.
And I have one thing that I'll be happy to go over with everybody, again, because you're busy filling forms out. There are 2 flyers in the back of your brochure that have dates on them that I did not catch are incorrect. So I have the correct dates for you. The adult IOP family and friends support group, the next one is actually on September 5th. Everything else is the same, it's just the date. It currently says July 25, it needs to be September 5th. And then the adolescent IOP family program, the next one is actually Tuesday, August 28th. It currently says June 19th. So I didn't notice that the dates were on those before we stuffed them into the folders. So sorry about that.